Rangoonwala Foundation, a UK-based charitable trust. Please give a big hand to Dr. Quresh Maskati.
Thank you, and it's good to be back again with you. I had to bunk Saturday, but I was with you on Friday, and I'm sharing this dais again with you to share my experience of now about 15 years since Chandrashekhar Chawan and I started use of the scleral lenses, visiting Perry Rosenthal in Boston, spending time with him, and then Chawan going over there and learning so much about these scleral lenses from Perry Rosenthal and the BFS, Boston Foundation for Sight, that Perry didn't actually want to let him go. Fortunately for India and for us, Chawan wanted to serve his home country and so came back, and then we discussed the role of scleral lenses for the conditions that I see as an eye surgeon, various corneal conditions, and that's how we landed up using these scleral lenses for severe ocular surface disease. So these facts are known to you already. So the scleral lens to eye relationship, why does it matter to an ophthalmologist? Because of the saline which is there, which will bathe the cornea, and therefore which will allow my severely photophobic patients with corneal surface disease to actually see the world. So for me that was a huge plus. I'm not going to talk about the optical indications which Prasad has talked about, the keratoconus, and Randy has talked about as well. So we'll talk about more the salient features in ocular surface disease, that it provides a continuous, constant, oxygenated aqueous environment. Oxygenated because it's oxygen rich, the high decay material of the Boston lens or whatever lens you are using. Then there's elimination of corneal friction on blinking. Again, a huge plus. In our Stevens-Johnson syndrome, many times we have what is called lid wiper epitheliopathy. The upper lid gets keratinized at the edges. So every time the eyelid opens and closes, the keratinized rough surface of the upper lid is rubbing against the cornea like a windshield wiper and scraping off the epithelium which is there. So there's a continuous irritation or a pricking sensation. So when the moment you have a scleral lens sitting on top, that lid wiper epitheliopathy or LWE as we call it is eliminated. It's a huge plus point for our Stevens-Johnson patients with lid margin keratinization. Otherwise we'd have to operate them and do a mucous membrane graft of the lids, which is again a surgical procedure. So, and as a bonus to them, they really don't care about the vision, they just want to open their eyes. But as a bonus procedure, when the eyes open, they see much better. So these are all the advantages that we get by fitting these scleral lenses in patients with severely compromised ocular surfaces. The biggest advantage that we see, if a patient of Stevens-Johnson comes to me and is severely photophobic, when I try to open the eye, he tends to roll his eye upwards. I know that this is the patient who is going to benefit the most with the scleral lens. The photophobia disappears like magic even before everything else disappears. So that's why I put light sensitivity of photophobia as the first reason for me for putting a scleral lens. Dryness, pain, foreign body sensation, burning, these are all ocular surface disease patients have in common. But the photophobia is the one which will go away first and which will really give the patient a wow effect. I've had patients who've been 4 or 5 years in Stevens-Johnson and hardly ever gone out of the house because even with dark glasses on, they're severely photophobic. And I put them on a scleral lens and they say, wow, and I can shine a torchlight into their eye and they're still keeping their eyes open. So this is a huge plus point, photophobia. So whenever you get a patient for fitting in an ocular surface disease that is severely photophobic, you know this patient is going to love you. So this is some of the slides are borrowed from Chawan. The before when they couldn't stand even in the room light, keeping the eyes closed, and afterwards even on shining a light, the eye is open. This is a patient who had Stevens-Johnson and keratoconus both combined, and she would spend her time in a dark room like this, and here she is opening her eyes and seeing the world. So severe keratitis sicca. Keratitis means any inflammation of the cornea. Sicca is drying, so any cause of dry eye. Virtually any cause. It could be Stevens Johnson, it could be Sjogren's, anything which gives you such an irregular corneal surface. And the moment you fit this is early on, you're already getting a better surface, and it just keeps getting better with time. So Stevens-Johnson syndrome, some of the patients I feel that we've been able to avoid the melt. Why have we been able to avoid the melt? Again, partly because of the lid wiper epitheliopathy effect, that the lid keeps on rubbing and scraping of the epithelium, causes an inflammatory cascade, inflammatory cytokines come in and cause the cornea to melt. So if the inflammation is reduced on the corneal surface, the chances of melt are reduced. So you're not only giving the patient symptomatic relief, but you're prolonging the life of these corneas by preventing melts. Because once a melt occurs, it's extremely difficult to manage. You can't do a corneal transplant in a patient whose tears are deficient. You're doomed to failure. In that case, you have to do the more expensive keratoprosthesis or the Pintucci keratoprosthesis that I do. And even those, the chances of success are only about 65%. So if you can avoid a cornea melt in a Stevens-Johnson by a non-invasive technique like a scleral lens, you're really helping the patient. Persistent epithelial defects. Now, persistent epithelial defects sometimes occur for various reasons. It could be an anesthetic cornea, it could be a post-LASIK patient, some amount of liberal stem cell deficiency, various causes to have a persistent epithelial defect. And no matter what you do, that epithelial defect tends to remain. So usually we treat these patients by autologous serum drops. That means we bleed the patient from the vein, we take out a few cc of blood, we allow the cells to settle down, centrifuge the thing, then take the serum which is there and dilute the serum to make it anywhere from 50% to 20% dilution, and use those serum drops because they contain growth factors and other good factors which help to healing. But that takes 4 to 6 weeks for that epithelial defect to heal. Sometimes that works, sometimes that doesn't work. So an alternative to that, or an adjunct to that, autologous serum drops, is a scleral lens, which can cause even a bad persistent epithelial defect to heal. And a prolonged use of the lens can prevent. I've had patients who I've bled the patients 3 times a year because every time they heal and then they break down again and then they would heal. And you can't keep bleeding the patient to make these autologous serum drops. So if you just keep the patient on for about a year of this scleral, these patients don't always need like a Stevens-Johnson a lifetime of these lenses. If it's not a dry eye patient, if it's some other cause of persistent epithelial defect, then a year to 2 years of scleral lenses and then they don't need them anymore. Then the neurotrophic corneas. Neurotrophic meaning there's something wrong with the nerve supply. So some patients are born with what is called familial dysautonomia or the Riley-Day syndrome, where the nerve supply to the cornea is not developed. So they are anesthetic. You get foreign bodies going into the eye and they don't know about it. They get persistent infections in the eye. So these patients need a long-term cover, and in these patients again the scleral lens is the best one because you can't have something sitting on the cornea. If it causes abrasions of the cornea, the patient will not realize it. So they need a scleral lens. So neurotrophic corneas would benefit from the scleral lenses. Congenital anesthetic corneas behave exactly the same way as I told you, the Riley-Day syndrome, where they would need these. Some severe dry eye syndromes like chronic graft versus host disease, Sjogren's syndrome, patients with severe rheumatoid arthritis. Of course, some of these patients need caregivers to put in and remove the lenses because their fingers are so arthritic they can't really manage this. And something called dysfunctional tear syndrome. What is dysfunctional tear syndrome? The tears are adequate in quantity, but the quality is so poor that they are causing more harm than good. So the patients keep their eyes closed in spite of having adequate tears in quantity. If you do the Sherman's test, the quantity is adequate, but the quality, they are full of inflammatory cytokines. Earlier we didn't have anything, now we have topical cyclosporin drops which alter the quality of the tears. To some extent there are other drops available also, the topical chloroquine drops in our country which alter the quality of the tears. But not all that great. Here if you take a scleral lens with a reservoir of saline, so there's no question of tears. The previous speakers alluded to the tear exchange which goes on. Now that's a gray zone. What exactly how much of tear exchange goes on? In a dry eye patient who doesn't have tears outside, there's really not much of tear exchange going on. He's lumped with the saline that you put into the eye. That's why a dry eye patient may need to take out these scleral lenses every 6 to 8 hours or so. He can't wear them the whole day because that the toxic tears over there accumulate. So he needs to remove the lens, wash it, put new saline in and wear this. And the drier the eye, the more time the patient needs to remove it. So there's no rule of thumb which says, yes, for a keratoconus patient, he can wear it from morning to night, but a dry eye patient may need to remove these lenses. So it's now well established that this scleral lens is useful in a variety of ocular surface disorders, such as Stevens-Johnson syndrome, dry eyes. We've been using it to treat a variety of corneal conditions since the last 15 years. I just checked with Chawan whether my figure was right. He says, yes, we did start in 2004. So it is exactly 15 years that we've been fitting this. Courtesy Chawan, who brought the technology to India from Perry Rosenthal, the late Perry Rosenthal of Boston Foundation for Sight. This is some of the early published work which Chawan and myself have done. Of the first 98 or 100 patients that we did with follow-up ranging from 6 months, and now some of these are completing 15 years. And this is the initial results that we had, which is pretty good for such severely ocular surface compromised patients. Almost 2/3 of the patients did benefit even with keratoconjunctivitis sicca, severely dry eye patients. And we did do some of the others like acid burn patients, congenital keratopathies, congenital cataracts, patients with aniridias, bad limbal stem cells. So these are some of the patients that we tackled, and we did get pretty good results. We then went on, Chawan and myself, to devise a new grading system called the Maskati Chawan grading system. That's only because Chawan is more humble than me, so allowed me to put my name first on this. In the management of Stevens-Johnson syndrome. So using the scleral lenses, we tried to see whether we could grade or find out which patients would do better than other patients. All Stevens-Johnson syndrome patients are not the same, and therefore all Stevens-Johnson patients don't, the lens doesn't work equally. There's no one magic bullet for any disease from head to toe, and so also for a complicated condition like Stevens-Johnson. It's not that the scleral lens will work for every patient. So can we decide, because it's an expensive proposition, before referring a patient with getting his hopes up to someone who fits scleral lenses and then having his hopes dashed because that scleral lens practitioner says, I'm sorry, you've got Stevens-Johnson, but for you, the type of Stevens-Johnson you have, this is not going to help. If before we send the patient for fitting, if we know it's not going to help, we don't send them. So we did this study, pilot study, to find out whether we could identify patients in whom it would not work and in those in whom it would work best. So unfortunately, no financial disclosures. So the purpose was to evaluate and grade the severity of chronic ocular manifestations in Stevens-Johnson, and then we use the MC grading system in evaluating prognosis and to evaluate the management of SJS using the scleral lens, and to compare the efficacy of scleral lens versus no scleral lens. So 72 patients with 144 eyes, because Stevens-Johnson is bilateral, confirmed diagnosis Stevens-Johnson, fitted with scleral lens, at least a year's follow-up from 2008 to 2010. All patients were at least 1 year after the acute episode with chronic ocular complications, at least 1 year from the onset. So these are all chronic Stevens-Johnson, nothing in the acute, because acute the management is totally different. We use a lot of amniotic membrane, and we use rings, conformers and things like that to prevent the dryness from occurring. Detailed history and ocular examination were done, and we took these 5 parameters. Of course, age, name, all that goes without saying, but the grading was done on 5 parameters. The first one is photophobia, how much of photophobia. C is for corneal transparency, how much of transparency. V is for vision, what was the best corrected visual acuity. BS is for superficial blood vessels, and BD was for the deep blood vessels. So these are the parameters we looked at, and each parameter was graded on a scale of 0 to 5. 0 is wonderful and 5 is obnoxious. So between 0 to 5 is what we graded all of them on. For example, P0 in photophobia would be no photophobia, even to very bright light. What is the very bright light that I use? The indirect ophthalmoscope shines a very bright light onto the cornea. So if putting on the indirect ophthalmoscope and allowing that light to come and he could tolerate that, it is P0 or no photophobia. Versus P5 who cannot even open the eyes indoors. So that would be the severest form of photophobia. Wants to keep his eyes closed even in ambient room light. So this is how you grade P0 to P5, and all other parameters were graded. So this and the other things were in between. So once we had this table with us, we could simply say that this patient of Stephen Johnson on onset was P3 or P2 or P1 or whatever based on this classification. So for example, this is P2, cannot tolerate moderate light from the slit lamp, he moves away. P4 would be wearing black glasses even indoors, and P5 is somebody who just wants to keep his eyes closed even indoors. Then we divided it for the rest of the classification, for the rest of the parameters, we divided the cornea into 3 zones, where zone 1 was the outer 2 mm peripheral zone, zone 2 was the 2 to 4 mm mid peripheral zone, and zone 3 was everything in between inside, that means the central zone. So we divided the cornea into 3 zones, zone 1, zone 2 and zone 3. So for corneal transparency, it ranged from C0, where cornea is clear, to C5, where there is complete keratinization, the iris is not visible, and then everything else in between. If the scarring was only in zone 1, we would call it C1. If the scarring was in zone 1 and 2 or zone 2, we would call it C2, because the more inside the scarring, the worse the prognosis. If the scarring was in central zone, zone 3, it would be C3. If all the 3 zones, it would be C4. And if there's so much keratinization that you couldn't see the iris, it would be C5. So if you see the picture there, you would know what grade is it. I would call it C4 because there was scarring right from the periphery to the center. But it's not C5 because you can see the iris from the top. So it's not C5, it is C4. So this is how we would classify the corneal transparency. Superficial blood vessels would be BS from 0 to BS5, where BS0 obviously would be no blood vessels entering the cornea, while BS5 would be superficial blood vessels going up to zone 3 and more than 50% of the cornea involved, and this is the in between. So for example, if you see a picture like this and just somebody shows you this and say what grade of blood, superficial blood vessels, I will say this is BS4. Why? Because the superficial blood vessels have gone up to zone 3, but less than 50% of the cornea, only from the lower part and 1 quadrant that the blood vessels are going. It's not the whole, less than 50%, less than 3 quadrants. So therefore it doesn't qualify as BS5. So it would qualify as BS4. So this is how you could grade the superficial blood vessels. The deep blood vessels are rated exactly the same way as the superficial, except on slit lamp you will see whether the blood vessels are in the superficial stroma or in the deep stroma. So this is again exactly the same, and if I showed you the picture there, what is the grade? You will say it's the deep blood. They are deep, you can make out even on naked eye because they are little dullish red, they are not the bright red that you saw in the previous one. But the classification will still be BD4 because it's in zone 3, it's going right up to the center, but less than 50% of the cornea is involved. So this is deep blood vessels. And the last of the 5 parameters is the visual acuity. So if the visual acuity was between 2020 to 2030, it's say excellent visual acuity, that would be V0, and visual acuity just hand movement or perception of light would be V5, and everything else would be in between. So we could grade all the 5 parameters like this from 0 to 5 for all the 5. Now let's take a few examples and you'll all become expert at this grading. So this patient 1, he presented with the following. P4, this lady presented with P4, she was wearing black glasses indoors. Her visual acuity was B3, that is 2080 to 2200. There was C4, there was scarring present, all the 3 zones were involved. There was BS4, blood vessels right up to the central zone, and the not involving the whole cornea, and BD4, so BS4, BD4. So I would write down grading on the first visit as P4, V3, C4, BS4 and PD4. Now this is what I would write. Patient would understand nothing of this. But when they fitted the patient with the scleral lens and called the patient a month later, 2 months later, or whenever the patient could come, because many of them come from long distance, I could then grade them again, put the grade against the top grade and see which parameters had improved. So after this patient came after 15 months with scleral lenses. Now I found that grading on the last follow-up was this: P1, V2, so the photophobia had improved from P4 to P1, huge amount of improvement. Vision had improved a little bit from V3 to V2. The blood vessels had regressed a bit, C3. The corneal transparency had improved to C3. The blood vessels had regressed a little bit, both in the superficial and in the deep. So this patient, I would say, is doing very well. Though the vision is not improved so much, the comfort zone, because of the photophobia improving. And this is what we saw in every patient with poor photophobia, as I told you. The photophobia improves the most dramatic with these lenses. Another patient, following classification, P2, V3, C2, BS1, BD, 0. There were no deep blood vessels. So this is the grading on the first visit. P2, V3, C2, BS1 and BD0. And when the patient came after 1 month of treatment, and I put one on top of the other, you see again photophobia improves to near normal. There's no photophobia anymore. The vision improved dramatically in this patient. So patient with good vision to start with becomes much better. So these are the conclusions that we are drawing. The corneal transparency and the blood vessels, because it was less to start with, it was pretty good to start with, showed no improvement. What improved was the photophobia dramatically and the vision. So we know that if the patients, Stephen Johnson is not so bad, they improve dramatically as far as the photophobia is concerned, and the vision will come back to normal absolutely. This is the third patient. So now here the patient has P3, V5, C5, BS5, BD4. Now, going by our past experience, we knew that if there is, the cornea is completely keratinized, C5 is the crucial giveaway. C5 means complete keratinization of the cornea. So if the cornea is completely keratinized, no matter how much of bathing you do of the cornea, nothing is going to improve. So this patient doesn't deserve. We put the patient on scleral lens because this was our learning curve. But subsequently when we got patients with C5 as a grade, we simply didn't even try scleral lenses because we know it's not going to work. So it's not fit for scleral lens. So the results, to summarize, in almost all the cases there is significant improvement in terms of photophobia and visual acuity. In some of the cases, this is something we didn't expect, there was relative improvement in the scarring and even the blood vessels entering the cornea, there was some amount of regression. And more importantly, we could identify patients who are not fit for scleral lenses, where the visual acuity is a little low and the cornea is completely keratinized. So these are the patients who should not be having these scleral lenses in the first place. So this is the summary again. Average visual acuity of presentation was 2050 to 2080. Average visual improvement was about 2 logMAR lines, and more importantly 2 to 3 grades of improvement in the photophobia was seen in these patients. So in conclusion, the Maskati Chawan grading system for patients is an effective tool for decision making about use of scleral lenses and to monitor the prognosis. And this new method of grading and severity of the ocular involvement, it shows you the severity and is correlated significantly with the final visual outcome. Another conclusion, it gives you a more objective way. For example, if you're using a scleral lens from A company and B company, you can compare apples to apples and see which one of them improves things better and therefore which one is better for the eye. So it's easy to compare using these parameters. And of course, you can measure outcome measures, scleral lens versus no scleral lens, as to how these parameters, again these 5 parameters improve. Does it improve the same way on conventional treatments or do you need scleral lenses? So the benefits, it can be used to evaluate any future treatment options. It's fairly easy to use. Once you get the hang of it, you can grade these and you can keep this parameters in a drawer in your front drawer, so you can refer to it when the patient is not in your room. You don't have to refer to it with the patient inside. And it will come handy to compare results of X company with Y company scleral lenses. The limitations are that we are only talking of the cornea. We know that the Stevens-Johnson is something which affects the whole ocular surface, which includes the lids as well, conjunctiva as well. But our limitation is that we are using scleral lenses which affects only the cornea. So this evaluating system is only to see corneal changes. Thank you so much for your attention.
Thank you, sir. We are honored to have you here. Before we all disperse for the coffee break, I would invite Mr. Nilesh Tite on stage to kindly felicitate our speaker. I request Mr. Chawan and Dr. Quresh Maskati to kindly come on